There we go. We should be recording now. You should have all had that message. So again, welcome to everyone for this evening of entertainment, as we know it, for East Lancs Hospital Trust Go Live for the SCS service. So that's the first test of the evening. What is SCS? So if you're on any other thing other than the smoking cessation service, you're on the wrong webinar. And I'm hoping you've got the correct one. Plenty of people have joined. So could I, in advance, just massive thanks to all the ELHT crew who's going to take us through the evening. Also to Janeth, the CSU crew, and also our team CPLSC, and all the commissioners who have joined as well. And of course to all our contractors who have took the evening out to get us prepped and get yourselves ready for the smoking cessation services. Obviously, we've avoided Halloween evening last night. So we thought we'll avoid a scary evening of Go Live. We thought we'll keep it for today, which probably works best for all of us. We might hear some fireworks in the background, no doubt, ahead of bonfire night, but I suppose that's additional entertainment. Right, so all of you probably would have had some comms previously that Airedale Hospital actually went live about a month and a half ago. So you may have already started to receive the odd referrals via the Farm Outcomes platform. So this is obviously directly linked to ourselves in Blackmore, Darwen and Pennine, which we're very pleased to announce. So on that basis, myself, as Chief Executive, Community Pharmacy in Lancashire, South Cumbria, Mubashir Ali, I'll hand over to Naomi to take us through the evening proceedings. Thank you very much, Naomi. Over to yourself.
Thank you. Hi everyone, thank you very much for joining us this evening. So I'll go through some introductions in just a moment, before just a few bit of housekeeping, little bits and pieces really. If you could all just please pop yourself on mute, just then we can clearly hear any speakers that we've got presenting. As Mubashir's advised, this will be recorded so we can circulate for any contractors that aren't able to attend this evening. So the plan for tonight is really just to give you a little bit more information about the smoking cessation service, just then you're fully prepared and ready ahead of the service go live, which is on the 6th of November, which will be Monday. So it's really just to give you everything that you need to get you prepped and feeling ready and confident for your referral starting to trickle through. So, excuse me, sorry, I'm just going to start by sharing my screen and going through some introductions. Okay, so my name's Naomi. I'm from Community Pharmacy Lancashire in South Cumbria. We've also got Bash, as he has already introduced himself, and Janeth from MLCSU. We've also got Laura and Michelle here from ELHT. And I will pass over to Janeth to take it from here.
Thank you, Naomi. So my name is Jan Ward. I'm a pharmacist at Midlands and Lancashire CSU. So some of you may already be aware that CSU has been commissioned by NHS England to support the implementation of the smoking cessation service. So I'm part of the implementation team. We're a small team, and I am the point of contact for the Northwest region. Could I have the next slide, please? So tonight, I'm going to give you a background on the smoking cessation service. Then I'll talk about the pilots whose findings were used to commission the service. And I'll give you an update on the implementation of the service. And at the end, I'm happy to take any questions. Could I have the next slide, please? So I'm sure you're all aware of the NHS long-term plan, which focuses on the importance of preventing avoidable illness. We all know that smoking is one of the biggest avoidable causes of disease and premature death. So treating tobacco dependency has been specifically identified as a key intervention that can contribute to preventing avoidable illness. So prevention is a core component of the NHS long-term plan, which sets out clear commitments for the NHS contribution to tackling tobacco dependence. It states by 2023-24, all people admitted to hospital who smoke will be offered NHS-funded tobacco treatment services. And this includes acute, maternity, and mental health services. The commitments are designed to be the NHS's contribution to helping deliver a smoke-free generation, to build on the good work already being delivered and to complement current stop smoking services, focusing on both physical and mental health services, and to introduce a level of national direction, but with local development and delivery. Could I have the next slide, please?
Here, Janet. Yeah.
So previously we've had smoking cessation programs in primary care, but the involvement of community pharmacy has been variable. We're all aware that hospitals are adopting the Ottawa model for smoking cessation in order to deliver or support the implementation of the NHS long-term plan. And for those who are not familiar or aware of the Ottawa model for smoking cessation, it involves systematically identifying patients who smoke when admitted to hospital, followed by brief advice, individualized bedside counseling, timely NRT or pharmacotherapy, and then the patient is followed up when they've been discharged. It is a 12-week program, and as mentioned, it requires follow-up. It requires follow-up of smoking cessation treatment after the patient's been discharged from hospital. It's been proven to increase the one-year quit rate by 11%. And when fully implemented, it's expected to save the NHS 85 million within 1 year. So that's a considerable cost saving to the NHS. Could I have the next slide, please? What is the aim of the smoking cessation service? Well, it's to support delivery of the prevention ambitions in the NHS long-term plan, and for community pharmacy to become a nationally available choice for patients to access smoking cessation support post-discharge. It is not to replace a locally commissioned service. It's to add additional capacity in the smoking cessation pathway and give more choice to patients. Could I have the next slide, please? So the smoking cessation service is an advanced community pharmacy service, and it follows on from the smoking cessation transfer of care pilot, which started in October 2020, with the first pilot site being the Royal Oldham Hospital that made referrals to 12 pharmacies in the Oldham area. Now, the pharmacies were selected following an expression of interest process, and it was important that the pharmacies gave good geographical coverage, as well as they had extended opening hours. There was a second pilot site down south, working with Guy's and St. Thomas's Hospital and King's College Hospital. And the data from the pilots was used to inform on how the nationally commissioned service would look like. And I should mention that the pilots have all transitioned into the smoking cessation service. Could I have the next slide, please? So this is data from the Oldham pilot, which took place October 2020 to December 2021, where 201 patients were referred to community pharmacy and 81 enrolled in the service. And this equates to a conversion rate of 40%. And this is actually in line with the number of patients who are being referred into the locally commissioned service. The 4-week quit rate was 57%, which is positive, really good result. And it was actually slightly higher than the locally commissioned service. And 19 patients completed the 12-week program. And that equates to a 12-week quit rate of 23%. I should mention that 41% of patients recording a quit at 4 weeks went on to record a quit at 12 weeks. So these are really positive outcomes and demonstrate that community pharmacies are well equipped to deliver on outcomes just as well as a locally commissioned service. In addition, the pilot did demonstrate that the referral pathway to community pharmacy was acceptable to patients. So I think that's another important point to make here. Could I have the next slide, please? So we had the pilots, and following the successful findings, that transitioned into the NHS smoking cessation service. And this led to a bespoke standard treatment program being developed by the NCSCT. Also, service funding was agreed between CPE and NHS England. So the consultation fees are paid for nationally from the community pharmacy contractual framework, whereas the NRT cost is charged back to the ICB, and that comes out of the primary care indicative prescribing budget. So local money is not used for this service. I think that's a really important point to make here. Also developed was the service specification was agreed, and this has actually been updated. It was updated and published June this year. The key change was that pharmacy technicians can now provide the service. So previously it was just pharmacists. So now both pharmacist and pharmacist technician can provide the service. Also, the service was launched to coincide with the National No Smoking Day on the 10th of March last year, with pharmacy registrations opening on the 1st of March last year. The service, the launch was a soft launch, and that took into consideration that the different acute trusts were different stages in setting up their inpatient services. Could I have the next slide, please? So I mentioned before that the CSU is being commissioned by NHS England to support the implementation of the smoking cessation service. So our role is around scoping and mapping. So this is where we meet with key people in the acute trust to try and understand the exact position of the trust in terms of their delivery of the relevant parts of the NHS long-term plan. We inform on planning, identify key stakeholders to support working groups. We facilitate implementation at local level. So advisors such as myself are available for each region across England. And we're here to ensure pilot sites transition successfully, engage with early implementers and those sites looking to start delivery imminently. Our team has also produced some supporting documentation and promotional material, and these can all be found on our website. Could I have the next slide, please? So what is the process of a trust to going live with the smoking cessation service? Well, it's a three-stage process, starting with stage one, mentioned scoping and mapping. So this is where we identify key people in the acute trust and arrange initial meetings and to get an understanding where they are in terms of setting up their inpatient service. And during those meetings, we try and get an intention to implement the smoking cessation service. So once we have that, it is important we have the right sort of people around the table. So the stakeholders, and that would include public health, LPC, of course, the acute trust, locally commissioned service, local authority people, and the ICB community pharmacy clinical leads. So then we would form working groups, and then we would move on to stage two, And stage 2 is where we try and understand and establish a referral pathway and a method for sending out referrals to yourselves. And at this stage also, the acute trust will agree on a go live date. So once we know that, we need to plan ahead and we move on to stage 3. So that's where we are tonight. And it's important that we engage with yourselves. It's important we have good geographical coverage, and it's important you're aware of the go live date. So for East Lancashire Hospital, it's the 6th of November, which is next week. So it's important that the staff are accredited. You've got your carbon monoxide monitors in place, and also a suitable amount of NRT in stock. And of course, where we don't have good geographical coverage, we would seek the support of the LPC. Could I have the next slide, please? So in terms of the referral pathway, we have a hospital inpatient undertaking a supported quit attempt. So upon discharge, there would be a conversation with the tobacco dependency advisor, and the patient would be given options. So whether to continue their smoking cessation treatment with a locally commissioned service or the advanced community pharmacy smoking cessation service, or the patient may opt for self-care. In that case, there's no transfer of care required. But the important point to make here is it is important that the referrals are equitable between community pharmacy and the locally commissioned service, and that it is patient choice where they want to continue their smoking cessation treatment. Could I have the next slide, please? So in terms of model of care, and this is taken from the original service specification. Step 1, patient is admitted into hospital and is identified as a smoker. And we move on to step 2. With their consent, the patient is given tobacco dependency treatment is initiated. And step 3, upon discharge, is a conversation, and in this case, the patient selects a registered community pharmacy of their choice where the referral will be sent. It has to be electronically in line with the service specification. So the step 4, a referral is sent to pharmacy. At the moment, the referral method is either the trust are either using NHS Mail or Pharmalcom. So East Lancashire Hospital will be using NHS Mail. So it is important you're familiar with the email address they're going to share with you where they're going to use for sending out those referrals. And step 5, so the referral arrives at the pharmacy. It is important that you contact the patient within 5 working days of receiving that referral, and that is in line with the service specification. If there's no response from the patient, then you must make 3 attempts, with the 3rd attempt being on the 5th working day of receiving that referral. And that is really to make sure that the patient doesn't run out of their NRT. So if you've contacted the patient 3 times and still no response, then it is very important that you inform East Lancashire Hospital that you've not been successful before you close that referral. So we move on to step 6, assuming you manage to get contact with the patient. And so the patient may consent. If they do not consent, again, you do need to let East Lancashire Hospital know that the patient has declined to participate in the service before you close that referral. So assuming the patient has consented, and of course, you can either offer face-to-face or remote consultation. And it is up to you and the patient to agree an appointment cycle. So that appointment cycle, it is very important that it overlaps with the NRT supply, and that's to prevent the patient running out. So that is step 6, and then we move on to step 7, post-event messaging. So you are required to provide East Lancashire Hospital with patient-level outcome data. So you need to, so really, there are 3 trigger points. So as the patient enrolled in the service, they need to know that. Secondly, the 4-week quit outcome and the 12-week quit outcome. And the information is all in the service specification. You also need to notify the GP that, you know, service provision to their patient. And at the end of the 12-week program, just to let the GP know, has their patient had a successful or unsuccessful quit attempt. Again, the information you need to send to GP is in the service specification. Could I have the next slide, please? In terms of training, so what do you need to deliver the service? You must have completed the NCSCT Stop Smoking Practitioner Certification. If you've already got it, you don't need to repeat it. And once you're a certified practitioner, you need to complete additional specialist modules in order to support pregnant women and people with mental health problems. You also need to complete a module to support patients who use e-cigarettes. Although e-cigarettes and vapes are not currently within the scope of this service, but you can still provide behavioral support to those patients. You also must have read the bespoke standard treatment program I mentioned earlier. And this just gives you a more structured approach to your consultations. And also it provides those effective and evidence-based behavioral change techniques that are going to give your patients a really good chance of quitting cigarettes. You also must be competent in undertaking carbon monoxide monitoring, and also be familiar with your SOP for the service provision. And all this is required really before the contractor signs up to provide the service with the NHS BSA. Thank you. Can I have the next slide, please? So just a quick overview of the service. So I mentioned the service is intended to complement the existing locally commissioned service. It's not to replace them, it's just to add additional capacity. You can see patients who are referred to you by acute trusts who wish to initiate or continue the quit attempt after they've been discharged. You must make contact with the patient within 5 working days of receiving a referral, and you must make at least 3 attempts contacting patient before you can close that referral. And you have to let the East Lancashire or the referring trust know. Again, you can provide support up to 12 weeks, but if you had a patient who's already received, say, a week support in hospital, then you can only provide 11 weeks support. Consultations can be fortnightly and can be delivered face-to-face or remotely via telephone or video link. And you can supply up to 2 weeks supply at a time of NRT. The course duration for NRT is 12 weeks, just note that. And if you want to know what products you can issue, there is a list in the current drug tariff. Can I have the next slide, please? You must make a clinical record on every activity pertaining to the service, and you need to undertake carbon monoxide monitoring for your face-to-face consultations. Again, this is a really good way to validate the patient's self-reported smoking status. And the service is completely exempt of charges. So NRT is supplied free of charge, even if a patient pays for prescription. So I think that's a really big advantage of this service. And as mentioned before, you must provide patient level outcome data to the referring trust, and obviously the patient GP, and the information is all in the service specification. In terms of fees, pharmacies will get a £1,000 setup fee, then it's £30 for the initial consultation, £10 interim consultations, and £40 for the last consultation, which can take place anytime from week 4 to week 12. And obviously, you need to make your claims via the to the NHS-BCA via the MYS portal. Could I have the next slide, please? So a quick update of the implementation so far locally. So so far in Lancashire and South Cumbria, we've got 3 trusts that are already live with the service. So East Lancashire will be the last acute trust that's going to be going live with the service next week. So that's fantastic. So I think after next week, all the acute trusts in Lancashire and South Cumbria are going to be offering the service. Could I have the next slide, please? And in terms of pharmacy registrations, now nationally, we've got over 4,000 pharmacies that are registered to provide the service. But locally, and I'm sure Naomi and Mubasha will correct me, I think we've got over 200 pharmacies that are registered to provide the service. And this map is taken from our dashboard, which again is on our website, which is a guide. It's not 100% accurate. But it just shows you implementation status of different trusts and also pharmacy registration trust status, sorry. So I will share the link to that shortly. Could I have the next slide, please? So here's some useful references, including a link to the dashboard. That's the 3rd down the list. And again, there's also a link to the service specification. And I think that brings me to the end of my presentation. Thank you.
Thank you very much for that, Jan. And we are ready now to pass on to Laura from ELH2.
Thanks very much. Naomi, is it okay if I share with my screen if possible?
Yeah, absolutely.
Only because I've just made a few amendments in light of a few things that have changed this week. So that's fine. Can you see that okay? You'll have to shout because I'm sorry, I can't see anybody now.
Yeah, I think you just need to put the slideshow, but yeah, all good.
Yeah, start the slideshow from there. Smashing. Thank you very much. So my name's Laura Walker. I'm the lead nurse for the alcohol care team and for the acute inpatient tobacco service at each Lancashire Hospitals Trust. So we cover a number of sites, but our main sites, particularly the acute site, is Royal Blackburn Hospital. But we do also have patients at outlier sites such as Burnley, Pendle and Rossendale sites as well. So we also have step down beds. So one of the up or down sides of going second is I suppose Janeth has already articulated sort of the details around the long-term plan and how this project has come about. One of the challenges for our trust was I suppose getting some of the resources together in order to launch the project. So there were a couple of us working in the background on this probably for the best part of the last year. Myself and Lucy Corrigan has been working as a part-time project manager. So we have managed to recruit a full team now, which I'll go on to talk about a little bit who we are and what we do. But just to kind of note, there are other models as well as the acute inpatient model. And so there's the family care model, And ELHT will also be launching a maternity service that will follow patients through the whole pathway that are pregnant. And there'll be specialist practitioners working with midwives within our organisation as well. So it's just something to note that there are 2 projects running in parallel, but also both projects will be launching at quite a similar time. I think maternity are just finalising some of their recruitment. In terms of our tobacco control initiatives, you know, we have the ICB behind us in terms of helping shape and develop some of this work, but we also have our strategic plans across the ICS, and there's been a number of conversations about vaping, which again has been mentioned. Our offer does not include vapes. Currently we are a smoke-free site, and that includes vaping at the moment as well. So what you might find is that some other models that are commissioned to continue smoking cessation, such as the recently recommissioned Lancashire specialist service, do offer vape. So there's a little bit of contention around that nationally, and different organisations have different views. So it's just to kind of make people aware that we won't be offering vapes as part of our offer currently. So based on these 30 seconds to save a life, the model is Ask, Advise, Act. So we want to keep it very, very simple. It's the 3 A's. So we will expect clinicians within our organisation to ask every patient who is admitted, and the grand ask really is every patient who presents to the trust, whether they smoke, whether they're ex-smoker or whether they're a non-smoker. To advise on the best way of quitting as being a combination of NRT and specialist or behavioural support. And to act, so that's about skilling up our workforce in terms of building their confidence and training around giving information about how to offer NRT, what to advise patients, and that they're more likely to quit, and then to offer referral to our service. So one of the things that we're keen to ensure happens is that services generally are the best people to sell their own services. So we're very much seen as part of the acute inpatient team. So we won't be creating any barriers. Everybody who wants a referral to the service will be referred, but we will expect that clinicians will refer to the service without consent. And the reason for that is to make sure that the patient gets the best care, that the prescribed NRT, but also where the specialist advisors come in is they'll be able to articulate and demonstrate to the patients exactly how to use the NRT, because one of the things that we quite often find is that when NRT is prescribed, unless patients are informed how to use it properly, you know, they might just assume to chew the gum or to not use it to its most effective end. So this is just an adaptation of the model in terms of who's accountable for which part. So during the inpatient admission, the admitting team, which will be the team in ED or the team on the acute medical unit, will start off with the Act, Advise, Act model. A referral will be expected to be made where the smoker is identified as a current smoker to our team, the tobacco dependency team. We will provide a CO test, an assessment of nicotine dependence, an assessment of the patient's readiness and ability to quit. And one of the things with being a smoke-free site that we have to encourage people to remember is not everybody wants to stop smoking. While that is the aim for a number of patients, about keeping people comfortable whilst they're in hospital, and encourage that seed planting about the thought process around giving up smoking. So as healthcare practitioners, we have a responsibility to ensure that people, particularly with the number of health inequalities we have with a lot of our patient groups, that we give them the opportunity to think about stopping smoking. But we also have to remember that this might not be their time. So that brief advice is absolutely key in moving them forwards in the next intervention that we can possibly have with them. So keeping people comfortable, but for those who want to quit, that's when the refer to pharmacy and locally commissioned services will come into its own, which is a later part of the model. We will revisit patients, so we'll be providing behavioural support throughout the admission. One of the challenges is sometimes knowing when that patient will be discharged. So there's going to be a lot of work going on behind the scenes in terms of tracking patients, thinking through when is the best time to refer on to local services and pharmacies, because discharge plans can change in an instant, and sometimes you can turn around someone who's been discharged. So there's going to be a lot of tracking to do, and so it's important that we get that information to patients right first time. So there will be a little bit of potential crossover work of phoning patients up post-discharge just to make sure that they're engaged and they know what the pharmacy arrangement will be for them post-discharge. The plan is to give all patients a minimum of 1 week's NRT. And because of the point of the year we're in now, and we've got a reasonable budget for NRT this year, we're possibly going to be looking at erring on the side of 2 weeks NRT, just to kind of maximise that potential for patients whilst that money's there ready to use. That could change as the project progresses, but it will be a minimum always of 1 week's NRT to take home for the patient. So the community team will book and a face-to-face follow-up appointment, whether that's with the local service or pharmacy. Now here is the key bit with this part of the project, is at the 28-day point, that submission of data around that patient's quit attempt, if they've been transferred to the pharmacy, will need to come back to ELHT, and we will report as an acute trust that 4-week quit to NHS England. So that's where the maternity pathway slightly differs, and it might differ from some of the other models. So it's just a key element that I think we just need to impress upon people, really. As Jeanette said, that will be done by NHS, not NET initially. The grand plan is that our new EPR system, which has only been in place for our organisation since July, will make the referral and send the data back. But there's a whole piece of work going on around that at the moment to ensure that that's a smooth transition. So that's why in the interim we will be using Excel spreadsheets and NHS.net password protected documents. So if one of the things I just wanted to ask all providers really is whether it's possible to send via NHS.net because of obvious information governance arrangements within our organisation. Just to kind of put a little context to the rest of the project, we have been working on this behind the scenes. So obviously we've thought about the staff offer, and I know there's a national thought around that digital offer coming. So that's just an update. We have got an offer for East Lancs to also anybody who works and lives in the area can also access specialist support services as well. So that includes people who are working within our organisation as well as patients, although our project won't typically see those people. I've talked about the smoke-free policy and the vaping stance. So that's where we are as an organisation at the moment, but we have been waiting for an ICB consensus statement around that. So as I say, things could change at some point in the future. I won't talk through this busy model because it kind of demonstrates what I've already talked about, but there's some of the data flows within this and the final boxes around that 28-day follow-up response back to the organisation. Ask, Advise, Act we've talked about. Again, this is just sort of going over some of the things that I've already talked about earlier on in the presentation. this is some of us. We have recruited a full team now. All team members are NCSCT trained. We have another half-time post and another full-time post joining us as well. So you may see some of the faces. I think we were hoping to get around some of the local pharmacies just to introduce the team and make those relationships as strong as they possibly can be. I won't bore you too much with the business case, but just to let you know, our smoke-free policy has been uplifted and approved in October, so that's brand new. We've got a data sharing agreement going through due process with the new community provider, but from conversations with Janet, there's nothing further that we need to do in terms of information sharing with pharmacies, which is really, really helpful. It means we can get going straight away. As previously stated, we launch next week. So we've got quite a lot of comms going, and we've signed up to the NHS smoke-free pledge as well today. So we've had Martin Hodgson signing in that, so that we're an organisation that supports this work stream. There's a lot of work that we're doing in the scenes, behind the scenes around training. So some of the other areas who've been launched for a significant amount of time, like Blackpool, have got some really good training initiatives that they're happy to share with us, and the hope is that we'll have a ICB wide training initiative. And just to say as well that quite often there is other specific training courses put on to support the standard training that smoking practitioners are expected to undergo. Just looking at some of the challenges, obviously our EPR and how we get that data flow back has been a challenge. We've looked at a few different systems, but alas, we're hoping to rely back on Cerner once that's live. We have to provide patients with an RT 2 hours after their admission. So unfortunately, we have only been commissioned as a 5-day service, and so that leaves Saturday and Sunday. So it's absolutely imperative that we train all the staff. They understand how to deliver NRT, and that'll be a huge piece of our work. We'll be educating clinicians so that we're keeping people comfortable and starting that quick journey as soon as possible. And I think that's pretty much everything in terms of coverage. So I shall just stop sharing.
Thanks very much for that, Laura. Last little bit from myself. I'm just going to again share the screen. So again, it's just a few little bits from us here. Sorry, I'll just have to skip through a few through Janet's presentation. There we go. Right, okay. So again, I'm just going to touch on a few little bits that have already been spoken about, but it's just really for your oversight. So referrals will be sent from NHS Mail to NHS Mail, which is your shared mail inbox. So for example, it'll be your pharmacy.fcode@nhs.net. So it is imperative that this is checked regularly. If you're obviously registered to the service, you're waiting for your referrals to come through, this is where you're going to be receiving them. So please do make sure that you are checking them and keeping on top of it. I mean, this should be checked regularly anyway, but obviously if you are waiting for these referrals to come through, please make sure that you're looking at it at least twice a day. The acute trust will include a read receipt on the referral email, just so you know that it's been received. I'll also give you a quick call just whilst the service is getting up on its feet, just to give you that little bit of extra support. Referrals will come from elht.tobacco-inpatient-service@nhs.net. For anybody that wants to make a note of that, please do so. There's no reason why it should go into junk, because obviously it's NHS Mail to NHS Mail, but it may be worth, just to be on the safe side, to make sure that you accept it as a trusted sender, to make sure that the referrals are going into your main inbox. So, as referrals are coming through NHS Mail, pharmacies will have to create manual reports, possibly using the templates in the spec appendices. Reporting is not currently done automatically by the system, but this is something that is being looked into. If you are using farm outcomes as well, this should pre-populate. So just a little bit about how to register if you haven't already done so. NYS has got a little bit of a new look, so we just thought we'd show you where you need to be looking and what this looks like at the minute. So as you can see on the left hand side, it is all in alphabetical order. So scroll down to the bottom, Smoking Cessation Service. When you click onto that, it'll give you all the information that you need to know before starting the service, what you need to be accredited with, the full details and requirements. There's a link to that on the NHS BSA website, and then it'll ask you finally if you want to register for the service. As Jan spoke about earlier, please make sure that you are service ready. You've got your CO2 monitoring equipment, you're fully accredited. And it's also worth letting the rest of your pharmacy team know that you are service ready, and it is something that you're providing. And also, it doesn't have to be the pharmacist that books the patient in for the consultation. So if you do have other members of staff that are on top of your NHS shared mail, they see a referral come in, they are able to contact the patient to get them booked in. So it just helps with that 5-day window. If you're keeping on top of that, just make sure that everybody within your pharmacy is aware. So service claiming, you will need to submit manual claims for the payment. Claims for this service should be made monthly via the NYS portal, and claims should reach the NHS BSA by the 5th day of the following month after completion of the SCS. So, wanted to talk to you a little bit about the farm outcomes template, as I know most of us are using this platform. What we'll do, we'll pop a link in the chat box with which will be a short video to show you how to manage manual referrals received via nhs.net mail. So we've highlighted it there. It's quite obvious that on the left hand side it'll tell you there's the NHS Smoking Cessation Service referral and registration. It's very, very simple. You just put the details straight from your email onto farm outcomes, and it's easy enough for you to manage. As mentioned, this will pre-populate to NYS as well if you are using farm outcomes. And that is everything from us. Do we have any questions? I know there's been some going off in the chat, but if there's anything else, please feel free to let us know.
Yeah, I'll just probably cover off a few of those. So many thanks to everyone for the questions and queries that we're getting through. Neural taking the lead there, which is good to see. Excellent on behalf of everyone, it sounds like, Neural, yet again, which is fantastic. So it's really important we try and cover some of this stuff off, because ultimately it's a contractor decision whether you wish to continue and take on this advanced service. And I think that is crucial. You've got to understand your own capacity restraints. You've got to understand your involvement, what you can and what you can't do, and hence why utilisation of this webinar and the chance to ask us any questions. And so I'm just going to run my way through a few of those if I can, and I'll go across the relevant expert parties if it's relevant, where appropriate, because I think Jonathan may have answered a couple as well within there. So I'm going to kick off with Nurul's first point, if I may. Ladies and gentlemen, so most pharmacies have NHS email, but most pharmacies do not use them. That's the first bit Nurul states. Fact. So there would be missed referrals. Farm outcomes would be a better choice. So I'll answer that in two parts. Number one, fortunately, although you may be factually correct, it is a terms of service, as Naomi pointed out, and you should actually be checking your shared mailbox at least twice a day for any urgent NHS mail communication anyway. So I thought I'd just point that out. Hopefully that answers the first bit. But you are right, farm outcomes may be a better option, and that was discussed across the wider ICB rollout. And I can again bring in Julie later on where appropriate if we have enough time, as you can probably clarify. But at this point, I would highlight, Nurul, that although we're starting with the NHS mail, and you do highlight refer to pharmacy later on, we are hoping whilst we work through this via appropriate individuals on the steering groups, that we are looking to utilise refer to pharmacy as a mechanic, as we've had across Pennine for a very long time, as being the route for the referrals to be picked up. I thought it's probably just worth highlighting. It's not a promise, it's just something we're currently working on as an easier route to work that through as a referral. Okay, I think I've answered the last bit there. Let's go on to Nurul's part 3. So too many contacts to be made and too much sharing outside of simple centralized system. I think that's a similar sort of question, which I've sort of answered, and you are right, which is why we're looking at refer to pharmacy. The next one is around CO monitors. Are they necessary? Yes, they are, and they are within the spec. Sorry, Jonathan, yeah?
Yeah, they are, and it is a good way to validate that self-reported smoking status. I think it is important to do monitoring, particularly for those 2 reviews. You have to do 2 formal reviews at 4 weeks and the 12 weeks. So I would strongly recommend that you kind of validate that self-reported smoking status using the carbon monoxide monitors.
Brilliant. Thank you very much for that, Jonathan. Actually, within the spec, which I have put a link in there for you, please review that in detail. It does actually specify and gives you within the appendices the minimum criteria for your monitors, and it also includes the specification around the calibration, and hence why the fee, which includes the training element and the purchasing of the equipment, is there for that £1,000 as initial payment to at least allow the initiation of the service. I thought I'd just highlight that. Janice, you got your hand back up?
Yes, just to add something else, it has to be a monitor also that can be used with pregnant women. That's within the service specification as well.
Brilliant. Thank you very much. And I have added a couple of manufacturers in the actual chat for you, those people who've asked that question later. A couple of options that are actually options which are within the SLA anyway, but I felt it might be useful for you just to understand and run through, and that probably covers off Janet's point as well. How do the fees compare to previous service? Neural question. So unfortunately, this is the first advanced service national level, so there is no comparative to any previous ones. The only comparatives, if you wanted to make it, it won't be like for like, maybe localized commission services, which of previous history, you'll know that the criteria and the payments were actually different, entirely different, actually, so they don't compare exactly. One thing I would point out, though, that was included in the presentation, this is a pharmacist and a technician-led service. Hence why the payment structures will definitely differ from localized commission service, which may have been and are still in Blackburn with Darwin, relevant individuals who are trained to that level. Hopefully that answers that question. On to Benjamin. You have gone and completed NCSCT, which is fantastic to see. Please continue with that great effort. And your question, I think, is why can't I be included? Do I have to wait to become MVQ3? Hopefully I've just answered that, which may be not what you want to hear, Ben. But yes, you have to be either a technician or a pharmacist to fulfill the nationally advanced service. That is unfortunately the case as it stands for this particular service. A locally commissioned service, may differ. And if you're in Blackburn with Darwin, that's different. And again, you can come back to the LPC and we can gladly guide you on that if that is necessary. On to the next question from Nurul. So how good will East Lancs Hospital Trust be with the referrals? One for Laura coming up here. Get yourselves ready. We have very little coming through on DMS, and that has completely stopped for the last 5 months with expectation that it should have been up and running months ago. Loss of income for contractors. So Nurul, I will just clarify on behalf of the Hospital Trust that actually you're in a patch which has had the highest number of referrals across the country for the last few years on DMS. Just to clarify, in support of the hospitals. But unfortunately, there's always going to come a point where even hospitals have to adapt and they go to the electronic patient record across their vast environment and their wards, which is why, unfortunately, we have seen a decline. That has started to come back on board, Nurul, just to give you a bit of an idea, refer to pharmacy. And we are starting to see those come through, which again is positive. But I'll hand over to Laura to answer that first bit on the actual referrals and the sort of numbers you're looking at initially. Thanks, Laura.
In terms of numbers, that's a very, very difficult one. I mean, because we now have EPR, we should be recording all patient smoking status. So there's a huge piece of work for our team to do around chasing through those referrals. referrals may have dropped. We've had previous well service doing referrals to pharmacy and to what was Quick Squad. And whilst this project's been sort of in development, there's been nobody really making any referrals because it's sat with occupational health before, strangely, which is why you may have noticed that drop off. Obviously, we want to make the service work. The practitioners we've got, and a couple are on the call, are very passionate. They've trained themselves as trainers, and I can never say NCSCT, but I think I have just said it right there. But they've trained a whole load of people over their careers. The people we've got are very motivated, they're very enthusiastic about the project. So, you know, in the same way as I suppose pharmacies would like to receive payment for things, unfortunately, we've had no payment for this project. So we've done all this work on goodwill, and now we launch next week. Obviously, we want to make it a success. It's the right thing to do for our patients. So we'll hope that you'll get many referrals. I suppose where patients choose to go is the only difference, whether they choose to go to local pharmacy, whether they choose to go to locally commissioned service. And that's something that's slightly out of our hands, I guess.
Brilliant. Much appreciated, Laura. Yeah. So we'll probably expect a smaller volume anyway, because it's just initiated. We're under winter pressures as well, so that'll have to be factored in. Also, we need to be realistic on our ambition as we start. Just moving on then. Nurul, I think this has been answered for you, but you asked a question around NRT products. Jonathan's kindly advised that will be drug tariff plus VAT rates for yourselves. There is an indicative price on the NHS BSA if you wish to have a little look. There is an indicative price, and that will obviously adjust each time the drug tariff is updated each month, and that is actually in line with most other services, even locally commissioned, because it's a baseline cost. Moving on, where do we obtain CO monitors again calibrated? I think I've covered that off as well. Mapinder, I've added a couple of links, and those are the businesses and individuals, and the equipment you'll need for recalibration is also in there, so you can get hold of those and purchase those as part of that initial £1,000. On to the next one. We have Ash asking the question, do we source our own CO2 monitors? Yes, you do. That's the contractor responsibility, and hence, again, the advance payment. Maksud asking the question, if we cannot contact a patient after referral, can we electronically inform ELHT? So the answer to that is probably in two parts, Maksud. So you'll get it via NHS mail. So your communication routes are obviously going to be via that mechanic. Even onward referral of that, because it's NHS mail, say you didn't have your NLT product in, you had to refer onwards to another pharmacy. That would be the route you would also use, because it's protected via NHS mail. You would forward whatever details you need via NHS mail to NHS mail to avoid any concerns. In terms of a payment, of course, if there's been no consultation, there won't be a payment attached, but you are right to send ELHT an email to say that hasn't obviously started a consultation and the patient has been rejected. Moving on, so we have Richard. Is referred to pharmacy still working? Not had one for ages. I think I've answered that for you, Richard, hopefully. So on to Maksud again. Can we arrange a single point of contact or source to recalibrate CO monitors? This was a key barrier to local services. Unfortunately, that isn't the case, because it's a contractor responsibility, and it's they can go to any provider they wish and purchase any equipment at whatever best rate they feel is necessary. Whether you decide to go collectively together at local level, that's entirely up to yourselves. But a very good question, and hence why CPE have actually added some frequently asked questions, which covers the calibration point on their website as well. I think the last question in terms of the chat function from who else? The Nurul, excellent. The objective is to have results. Spot on, very good, positive. If the process is long-winded and time-consuming, you will lose contractors' enthusiasm to deliver the service, given the challenges community pharmacy already face. That is all fact, and you are absolutely right, which is ultimately why it has to be a contractor decision to participate. The funding is as specific as a nationally advanced service, which has been negotiated at the correct rates. and including the £1,000 advance fee. So the workload has been married up to the requirements that you probably want from a technician now. Before, remember, Noodle, it was a pharmacist, and now it's fallen to a technician as well. So you've got some workload gains I would probably highlight, but ultimately it's the contractor choice. And to move ahead in the pharmacy profession, services will form a very important part. And again, it's entirely your choice to proceed. But hopefully that gives you a bit of an indication that we have a positive stance. Hospital are also very keen, as you just heard from Laura. And smoking is just a huge initiative and ambition across the whole board. And it's a critical area that we all need to play our part. Right, that is the end of the chat function. Just as a matter of course, it is gone past. I'll probably just open it up one final point for anybody to put their hands up if they wish to come forward. Any final questions? If not, we will close the call. So I'll just open it up for any final questions. Any hands up? Janeth, over to yourself.
Yeah, Mubashir, I just wanted to add, if a contractor has registered to provide the service and for some reason they're not able to provide the service, or the pharmacist who is accredited has moved on, or they've gone on mat leave, we are asking if you can deregister, because it is important we have a quality list of pharmacies that the trust can direct referrals appropriately, because it is very difficult to get the patient to engage in or agreeing to stop smoking. So if they're referred somewhere and they're not providing the service, it's very difficult then to get them to engage in the quit attempt. So that's why we really are asking, if you have registered and down the road you can't provide the service, it's so important that you deregister from the list, so that we only have those pharmacists who are service ready. It's just to give more confidence in the service. That's just important.
Brilliant, Janeth. Much appreciated. That's actually fact, and that's coming from the commissioner line as well. Right across the whole of the ICB, we are making calls on that, Mark. Laura, over to yourself.
I just wanted to ask about those who are ready, really, and what kind of numbers we have got on. Do we know that, or is it wait and see?
So we have got some stats which we have shared. So across the other sites, it's been again a slow-ish start, but we have had other sites go live, and the initial phase is literally a handful of referrals in the first couple of weeks. But as it starts to pick up, we start to see a bit of variation between some heading towards obviously locally commissioned services and those heading into pharmacy. But we probably make some active support calls at CPLSE in support of our contractors on some of the points that Nurul has said. We'll probably make about 10 or so calls a week to some of those active referrals. So some numbers vary, but as the service grows, it will continue exponentially start to grow as well into double digits, and they're hitting 30, 40, 100, 200 a month. It just depends on the activity from the hospitals once you're live.
Yeah, just so that we can point people in the right direction next week. It's who's ready to go, who's got the monitors, and so that we're setting people up to succeed.
Yeah, you're absolutely spot on. We are just slightly over. I think Julie, I don't know if you are still on. I'll just bring you in if you want to discuss anything on the commissioning front, or as the community pharmacy integration lead. Anything else you'd like to add yourself?
Thank you for putting me on the spot there, Mubashir. No, nothing to add from me. I think it's been an absolutely great evening. The information out there and the presentations have been spot on. So you know where we all are if you do have any queries going forwards and things. You've got support from Mubashir's team as well as our contracting team at the ICB. So yeah, just reach out if you need anybody.
Oh, brilliant. Much appreciated, Julie. Thank you very much. And we are just ever so slightly over. Hopefully that has been beneficial to all. As Julie said, we are here to continue to support. Any questions, SLAs, any requirements, etc., you feel free to give us a shout, and we will aim to help you as best we can. Other than that, many thanks to all the presenters again. and it's been a great evening. And on that note, I shall say thank you and goodbye to everyone. Much appreciated. Thank you.
Thank you.
Thank you.
Bye.
Thanks, Mubasha.
Bye.